Just after 11 a.m. Saturday, it is time for the Dr. Payne Show. Dr. Lou is here. 1-855-55-DRLOU. Dr. Lou, that's the way to get a hold of her. info@paincarecanada.com. Or your third option is to call in today till 12 right here. 416-870-6400, star 640 on your cell phone.
The third option's the best option.
That's, for now. Like
and
immediate.
you know what's nice about it? Once you call in with your issue, you'd be surprised how many people call me after saying, I have a similar issue to that caller that you were talking to about blah, 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 blah. So
enlighten us.
Yeah,
please.
There's never a bad question. Never a bad question. I'm always interested to hear everything, even people who want to challenge me on things. I've had a couple calls in the last few weeks on people trying to challenge me on my different points of views of things. No problem. I'm happy to have an educated, critical conversation with anybody. I don't, the one thing that I like to say about healthcare is I don't believe that we for sure don't know everything yet. There is so much that we are going to find out that won't even be in our lifetimes. Yeah. Right. And it's just a lot of those things that we may think is absolutely ridiculous. Who knows? Maybe there is something about it. I'm not really sure. Like, all we can really do is comment based on the best evidence that we currently have, clinical experience. And then again, as I always say, whatever it is that the patient wants, because you can have something that all the research in the world supports. You've seen 100 patients, all 100 patients do great with it. But if the patient says no, well, guess what? It's a no. Yeah. And that's a big thing. But, that is our method. Is really trying to deal with people based on the best evidence-based method that we have. Now, that doesn't mean I'm somebody that's completely, against any type of alternatives or things like that. I always say, if you're doing something and it's helping you with whatever your issue is, whether we can explain it scientifically or not, if it's helping you, so be it. The only thing that I am ever against is scare tactics. I don't like hearing about people that have gone to different places or different people where scare tactics have been employed, where they're talking about things that really make no sense whatsoever. But as long as it's like, if you're getting a red flag, and it's pretty incredible how many people I've had call me that say, I've been going to this place or I've been seeing this person and this is what they're telling me and I feel like it's a red flag. And it's like, well, are you still going to see them? Yes. Wow. Like if you got a sensation that there's a red flag or something's really not right, you
listen to it.
Yeah, listen to it. Like, those gut instincts should not happen with somebody who is telling you everything up front. It should really make sense. Anything in healthcare should really make sense to somebody. Even if it's a little bit out there, but as long as you're not being scared into anything, you're not being told something that makes you feel afraid that if you don't do it, you're missing out on something. Those are just scare tactics. That's all just guerrilla marketing type of stuff to get people in the door. And that's my biggest pet peeve in the healthcare industry, is hearing these things where people are scared into doing something. You shouldn't be scared into doing something. You should be doing it because it makes good sense to you. And a lot of these things, I always challenge your healthcare professional as to why. Why are you doing this? Ask the benefits versus the risks. Also, another big thing that healthcare professionals that I try to do with everybody is, if I'm going to recommend whatever A, B, and C, I'm also going to tell them that there's an alternative D, E, and F. Right? It's just so that they know there's other options. I will give them the answers to why I believe A, B, and C are the better options, but that doesn't mean that, the other options don't exist. And it's very important that people know that. People should always, we always talk about informed consent. People need to understand what's about to be done to them. They need to consent to whatever it is to be done to them. And consent is an ongoing process. So if you've had a procedure today, and just because you signed a sheet of paper today that says, I want this done, and you go back tomorrow or the day after for another treatment, and all of a sudden you don't want that procedure, and you tell your practitioner, that's a big thing. You have to communicate it, right? Because they're not a crystal ball. They don't know how you're feeling. But if you say, you know what, I don't want that again, then consent is an ongoing process. They shouldn't be doing it. And legally, that is very, very true. It's an ongoing process, and you need to make your practitioners aware of what it is you don't want and do want every single time. In fact, based on a lot of rules out there, the practitioner should actually be asking you every time, is it okay that we do this again today? Now, I could see where a practitioner gets busy and you may forget to always ask that, but I think the responsibility should also fall with the patients. If you don't want something or something is not helping, you need to communicate that. We have meetings with our practitioners all the time to just go over cases and things like that. Another thing that's pretty remarkable is how many times we have a protocol in place that, we follow up with people to see how they're doing. Like if they haven't come back, like what's the reason? We always want to make sure that our quality of care, our customer service is as good as it can possibly be. And, sometimes people will say, oh, I didn't come back because, I came 2 or 3 times and I wasn't feeling any better and I don't think what was happening was working. And then I'll go look in the files and it's like patient reports they're feeling better. And it's pretty remarkable how many people are afraid to tell their practitioners the truth. And I always found that really, I know you and I will sit here and say why, but the reality is maybe they don't want to disappoint the person. They don't want them to feel like, they're being insulted, but it's not about insulting. You need to tell, and I tell everybody, no matter what, when I send them to someone else, no matter what, you have to tell that person the reality. If you feel worse, if you don't feel better, you need to let them know. It's very, very important that you communicate the reality of your situation, because if you don't, how's that person supposed to know? How, if you're telling them, it's one thing if you don't say anything, but even more, a lot of the times, again, it's remarkable how many times I see that person says that they weren't feeling better, but then I look at the charts and it's like, yeah, but they reported that you were feeling better. And I'll challenge people on this. I'll say, but you told the practitioner that you were feeling better. It's like, yeah, well, I didn't want them to feel bad. And it's like, well, it's not about them feeling bad. No. It's about you getting better. And you need to report that, because that's how people reassess. If you go back and see someone and say, hey, I'm feeling better, then that person is automatically going to assume, well, whatever I did last time clearly worked. Let's keep doing it, because diagnosis through treatment. And yeah, it's pretty incredible how many people don't want to tell the truth, or not. I guess not that they don't want to tell the truth, but there's an apprehension to make your healthcare professionals feel bad. It's not about that. You're not hurting anybody's feelings, and a healthcare professional should be professional.
They've heard it before.
Yeah, they've heard it before, and I'm always happy to hear, hey, I'm not feeling better. That's not working. Okay, fine. Well, we got to change. We got to change it up. Maybe we've got diagnosis wrong, and we got to look back. And that's a big thing I always talk about. You're given a diagnosis, but there's also diagnosis through treatment, because if your treatment intervention is working, then likely your diagnosis is right.
Right. 416-870-6400 star 640 on cell. Just getting warmed up. Lots of time to call in. You have health concerns, pain problems, bring them on. Dr. Lou is here to talk to you till 12 o'clock today. Dr. Payne Show, Global News Radio 640 Toronto. 1112, Dr. Payne Show, 416-870-6400 star 640 on your cell. Issues. Love to talk to you. Michael, good morning.
Good morning. How are you?
Good. How are you doing?
Good, thanks. I was just calling about to find out what the treatment is for a torn rotator cuff.
Okay.
I was in a car accident, say, about 8 years ago, and shortly after I developed it was getting severe throbbing pain in my right shoulder. So I had an MRI, and it showed that there was a full thickness tear.
Okay.
But then, after just resting for a couple months, it went away and never had an issue with it up until last December when I re-aggravated it. I don't know, I guess through working out and so forth. And now it's just to the point where my shoulder is basically useless. I can't do any pushing motion with it. It's keeping me up at night, and I've lost range of motion as well. And so I just finished an MRI this morning, and I just want to know what the treatment is for a full thickness, for a torn rotator cuff.
Yeah, and I guess the big thing here, because it's not as simple as just what is the treatment. It always very much depends on the circumstances around what the tear is. And as an example here, like let's hypothetically say you get this MRI back and it says that your rotator cuff looks the exact same as it did. When did you have the first one? 8 years ago?
Yeah, something like that.
Yeah. So now the question becomes, well, is it that tear that's actually causing your problem? Because if it doesn't look any worse, and sometimes it may even look better, then how can we deduce that that's the reason? And again, that's hypothetical, right? Because you may very well get it back and it looks much worse, or there's something else there, and so that would give us a clearer answer. But a lot of times what I see is this type of scenario where someone's had a history of something, they've had an MRI, an ultrasound, whatever, you get a new MRI, new ultrasound, x-ray, whatever it may be, and overall on an image, the condition looks stable, but their pain is much worse, or their symptoms are aggravated. well, then that's where I like, one of the biggest things that we always talk about is correlation of what we see clinically versus with what's seen on imaging. And a radiologist's job is to spit out everything that they see on that image. But a radiologist will also always say they need a history and they need to correlate it clinically with what's going on in the patient. So it's the job of whoever ordered the MRI or whatever imaging modality to be the responsible person to correlate, okay, is what we're seeing on imaging the result of what we see clinically? And that doesn't always match up. So I would say that's step one, right? Is making sure that whatever it is you're feeling matches up with whatever we see on the imaging. That's always step one when I meet a patient like you. Step two is if it does match up and it is a torn rotator cuff, the question becomes, this is, I'm always, of the opinion to try most conservative and least invasive all the way to more invasive and less conservative. So that usually means starting with things like physical therapy, passive modalities, progressing to rehabilitation. That's not working, maybe injections, blah, 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 all the way up and until surgery. Now that very much, again, depends on what we see. You've lost range of motion. You're saying that your arm feels pretty much useless overall. It may be something else going on. Maybe you've got frozen shoulder developing. I don't know. I'd have to assess it to be sure. But there's a lot of things that could be happening. What I would say is once you have the results of the most recent MRI, it might be a good idea to come in, see me for an assessment. And that way I can do a physical exam on your shoulder and really get a sense, okay, is it correlating? Is what we're seeing matching up? Because, again, there's a lot of things that cause pain in the shoulder. And I see this all the time where people say, oh, I was diagnosed with a tear on imaging. And then for fun, sometimes I'll say is, okay, let's get imaging on the other shoulder. And, oh, look, they have the exact same type of tear or exact same type of degeneration. So can you equate that is the result of the pain? Probably not. It might be something else. It might just be a functional issue. It might be because you use that side more, or you compensate in some way. So you got to look at the whole picture. So I guess, I've drawn out the answer, but the simple answer is the treatment very much depends on the entire circumstance.
Okay. Well, I have started seeing an osteopath.
Okay.
And she's the treatment is painful. It's not a cakewalk. But afterwards, she does loosen it up, and it does feel a little bit better. But
and have you been? Does she have any idea of a diagnosis? Does she think it correlates clinically with the imaging? Like,
to be honest with you, I just recently, I've only been to 2 appointments with her, and I just sent her the report from the first MRI. Okay. And I've yet to talk to her about it, but I will do that. But. When I get the new report, obviously I'll forward that to her as well.
Yeah.
Okay.
So, okay.
Well, sorry. Appreciate that, Mike. 416-870-6400 star 640 on your cell. Keith, how are you, pal?
Been better, sir.
All right.
How are you, sir? I've been thinking of calling you for years, but I finally did.
Good. What's up?
I'm right now. I'm in Lindsay Hospital, and for years I had gout. I've had gout since started in '96, so they put me on all kinds of stuff. I ended up on indomethacin. I think the doctor knows it, and it's just pretty well destroyed. Recently, we found out my kidneys, and then they did a kidney test on me, and you should be around a 90, and I was around a 6. So they've rushed me to Lindsay Hospital, and I hurt everywhere. And I want to know, is there some way I can stop this pain? I'm so sick of hurting since '96. I probably almost want to get a gun. So I finally broke down and called Dr. Lou here and see if he has any suggestions.
Yeah, well, it's obviously, number one, very loaded, and it's going to, obviously I'm not going to be able to answer what you can do over the phone.
What can I do for pain?
Yeah, and it's, again, that is a very, when... Let's start from kind of the beginning here. We're dealing with something that's as old as 1996, you said?
Yeah.
Yeah, so that's a long time, right? That's 20 plus years of pain. Yeah. So now, even assuming if we could just get rid of all the physical issues around that pain, again, one of the things that's important to consider with pain is the neuropathic component, the component of the learned behavior behind pain, how pain very much exists in the mind as much as it does in the body. And that is the part that's really, really difficult to deal with. In fact, we're pretty good at dealing with acute pain in terms of a healthcare system and what we know. Like, someone sprains an ankle, we can get them out of pain pretty quickly. It's really the chronic issues where we suffer, and it's, we've done a lot of shows on this. It's very much a multi-pronged approach. It's not one thing. And the other important facet to remember here is that, is there a cure? I would be lying if I said yes. It's management. If someone's diagnosed with diabetes, they often know that they're going to be on some type of medication for the rest of their life. Pain is very much the same things. You can target it from the physical perspective. And if we break down the physical perspective, we're dealing with things like, from the chemical perspective with medication, from the physical perspective with maybe some type of therapy or multiple types of physical therapies, chiropractic, acupuncture, whatever thing. Maybe there's some type of bracing solution that's involved, or a device to help, whether it's a walker. Again, depending, I don't know your whole history. I'm just kind of talking out loud here. Then there's the social aspect, right? Like the people around you and how they feel and how they treat you very much is going to contribute to your psychology, and that's going to contribute to how you experience your pain. So you have to deal with the relationships in your life from all different perspectives. Then you have to deal with how you see this pain, right? If you are someone that lets it take over your life, it will take over your life. If it's all you think about, it will equally be all you feel. And I'm not suggesting that it's easy to just say, well, I'm not going to think about it. But there are psychological ways and cognitive behavior therapies that can help to teach you how to start to break that a little bit. So, is there an easy answer for you, Keith, where I could say, yeah, here's what you could do for your pain that you've been suffering with for 20 plus years? No. And if anybody tells you that, it's a lie. What I'm going to tell you is that it's going to take a lot on your part, and there's so many different things that need to be involved. Stay on the line, Keith. We'll continue on the other side of the break.
Keith, we'll get back to you, and we have room for you as well on the phone lines, 416-870-6400, star 640 on cell. Dr. Payne Show continues, Global News Radio, 640 Toronto. It is 11:23. Yeah, 416-870-6400, star 640 on your cell to call Dr. Lou. Get your questions answered. info@paincarecanada.com as well. And when the show is over, you want to contact the doctor, 1-855-55-Dr. Lou, DRLOU. Keith, thanks for hanging in, fella.
Yeah.
So,
anyway,
yeah, Keith, are you kind of hearing what I'm saying? Like, is it making sense?
No, I understand. I'll have this forever. I just don't want to hurt so much.
Mm-hmm. Yeah.
I still do everything I'm supposed to do, but slower.
Mm-hmm.
You wouldn't believe it. In 73, I climbed up and put the light on top of the CN tower.
Oh, no kidding. Wow.
Nice.
That's my claim to fame, but now I'm kind of slow.
Mm-hmm.
I understand I'll have it forever, and I have to treat it. But the drugs are hurting me.
Mm-hmm. Right.
There are some drugs that are less harmful.
Yeah. So what?
I've been on hydromorphine and Cesamet. I was on the fentanyl patch, and they took me off it because of all this opiate scares. And I don't want the drugs. I want something less harmful.
Yeah. So one of the things that I would suggest is, and I get tons of calls about this, about people on different types of medication, whether they want to be on more or less. What I always say is you got to talk to the people who initially prescribed it to you, because they know the extent of your history. It's not as easy to just go to somebody new and say, get me off. That can be just as dangerous as being on too much of it, right? So you need to gauge that very, very meticulously. And then there's other things to be considered, like, medical marijuana, as an example. There's some very interesting stuff that's happening with the research around it, with pain management. Now, the research isn't great. We don't know a heck of a lot, but obviously the side effects of that type of medication is much, much less than what you get with the narcotics and the opioids. Is it necessarily as strong? Will it work as well? Again, it very much depends on, maybe it does, maybe it doesn't, but might be worth a shot. Then there's other things, again, going back to, you shouldn't only be thinking about what is it that I could take in order to feel better. It's also about the other things, like, as simple as, do you smoke, drink, how's your diet? Like, give me a little bit about yourself with regards to that.
I don't smoke or drink.
Okay.
I've lost 150 pounds this year. I used to be 300 pounds. I'm 150 pounds now, 6 foot tall.
Yep.
I have a hard time eating because I bring a lot of it up.
Okay. Yeah.
In the last week, I've had a lot of nausea.
Okay. Yeah. And so sometimes that is just as dangerous as being overweight, right? Like you need to replenish your body's fuel system. And if you're not eating well because of how you feel, then that is also going to affect you. And working with someone on how, like a dietitian, on how do I get around this? How can I keep the foods down? How can I get the nutrients that I need? There needs to be ways around that. And that's why chronic pain isn't something that one healthcare professional deals with. It's a whole team of healthcare professionals dealing with your pain, and again, in the form of like diet, injections, medication, therapies, psychological intervention. All of those things are very, very important. And so, I mean, it's a conversation for you and I to have, obviously, off the air about the extent of your case and have an assessment, and we can put together a plan for you. But these are not easy plans. They're not simple solutions. I don't lie to anybody from the get-go when it comes to chronic pain. There's nothing simple about it. And if you want to do all of it minus one part, it makes it work that much less. Like, a lot of people are good with the physical stuff, but once you start talking about the psychological, they're like, they don't buy it. But I'm telling you, that's, if not more important, at least equally as important as the physical side of things. And I would argue it's more important because of how much your brain controls everything. And you need to really control the mind in order to control pain.
Can I come and see you when I get out of this hospital?
Yeah, give me a call and we can set something up for sure.
If I get out of the hospital.
Hopefully, yeah.
I was near death. They made me come.
Well, best of luck to you, Keith. But yeah, absolutely. If you get out, please come see me.
Keith, 1-855-55-Dr. Lou, DRLOU, or info@paincarecanada.com. That is a perfect example of how, over the long term, pain can not only become a physical thing, but gets in your head.
50 in February.
Right?
Yeah.
It can just wear you down.
Yeah, it's, that's a person who sounds, unfortunately destroyed. And the reality is that is very, very common. That's what people don't realize about pain, right? Because it's like, it's not one of those things that seems life-threatening. And I guess that's why there's not a lot of focus around it, right? Like, we have a Heart and Stroke Foundation. We have the Rides to Conquer Cancer.
All these things.
You have all those things because those are scary. They're life-threatening. You don't have a lot around on pain.
Because you live with pain.
You live with pain, right. But think about what it can do to you.
Exactly. 416-870-6400, star 640 on cell. You have pain concerns, questions that raise anything in your mind. Bring it on. We'd love to talk to you right till around noon this morning. Dr. Pain Show, Global News Radio, 640 Toronto. 11:31, still a little less than a half hour to go. 416-870-6400, star 640 on cell. Osteopath.
Yeah, so I want to approach this subject very, very carefully because I don't want to obviously insult a profession I'm just using osteopath as the example because we got the call from the first caller with the shoulder issue saying that he had started seeing an osteopath about this. One thing that I would always, and again, I'm trying to think of the proper way to go about this, but for anybody who's suffering from something, number one, I think it's very important to have a proper diagnosis, not just an X-ray or an ultrasound diagnosis that someone told you is there, and then all of a sudden you go somewhere else and you just get it treated. But I would also say always make sure you know the professionals that you're dealing with, what their credentials are, how much schooling they have. Do they really understand this stuff? So let's take, for example, a profession like osteopathy, and I have osteopaths that work with me. This is not something like I'm saying it doesn't work or it's not beneficial. Yep. It's incredibly beneficial. It's an incredibly important healthcare profession. But sometimes you get these standalone practices and people just don't realize there's not very good regulation around osteopathy in Ontario and in Canada. It's not like in the States where a DO, a doctor of osteopathy, is a medical doctor. They're doing the exact same training, et cetera, et cetera. Here it is extremely different. It's an osteopathic practitioner. It's a diploma. Mm-hmm. These schools are often not regulated. There's no regulatory body. They don't have good regulation in terms of even after they finish schooling. And I've met some osteopaths. Now, equally, I've met other professionals that don't know anything, but I've met people like all I want to get across is be sure you know who you're going to with your problem. Yeah, it might be better to go to someone who says, hey, go also. So part of our team, it's like, you should also be seeing the osteopath for blah, 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 blah. But to just say I have an injury and I'm going there straight off the bat, I'm not saying is not necessarily the right approach. There might be, I've met osteopaths that are incredibly knowledgeable. They've done a ton of extra research. I just wanted to come across and say, make sure you know where you're going, make sure the extent of the person's knowledge, how much schooling they've done, do they understand how to read an x-ray or an MRI and truly understand how to correlate that. So, and that goes for any practitioner, not just, again, we have osteopaths in our team. They're incredibly important. I refer to them all the time, but there needs to be a way to properly, a proper chain of command and proper
some
management
due diligence
structure.
on your part, right?
Yes. Yeah. Thank you.
We'll get to a call. John, good morning. How are you?
Well, could be better.
All right.
Yeah, so like I said to the screener there, I was in yesterday for a colonoscopy procedure, which was set up the week prior when I attended the hospital. I had, like, severe abdominal pain, and it was determined at the hospital by just the drumming on the stomach and lower back area that, well, you're constipated, right? And, blah, 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 and we're going to set you up to go for a colonoscopy, but, and the emerge doctor said, try some Metamucil, which I told him hadn't worked for me before and caused other issues. But anyway, that was the long and short of it. So then went through the procedure with the purge, and my personal physician, when I saw him yesterday after the procedure, I told him about it, and he said, he basically said that it was, because of that, the purge itself, that I find myself today that I feel as though I'm being crushed internally. Okay. And I'm just wondering, is that something that would be normal, like a normal, result from that the procedure?
Yeah, so I'm not a GI specialist, so, I'll comment to the extent that I can comment.
I understand that.
Yeah. After any procedure, is some level of pain or a lot of pain possible? Yes, absolutely. It's still something being done to the body. I mean, a colonoscopy is not nothing. They are shoving a tube through your body. So, it could maybe have releasing everything that's being built up. Change something? Yeah, absolutely. Like once your body very much adapts to its circumstances, right? So if you're very, very constipated and it's gotten used to that over X amount of time, all of a sudden it's used to that, and then somehow you do something to really change that right away, like the purge.
Shocking.
It could be a shock to your body. Yeah, although it's probably better for your body to not be in that state, it's still some type of a shock. So, is it normal? It's hard for me to say. Is it absolutely normal for you? It doesn't sound like it would be abnormal for your body to feel that. I would encourage you, obviously, to, if it doesn't get better, or obviously if it gets worse, 911, but if it's not getting better, follow up. But, this is still relatively new. I think giving it 48, 72 hours, and as long as things seem to be progressing in the right way, I would say that that's probably a good thing. But if at any point you don't feel right, I mean, you know your body better than anyone else. If you're not feeling right, then maybe you got to go to the emergent and get it checked out.
Because like I said, I went to my physician afterwards. I told them before the procedure that after the purge, I did feel quite a bit better. But yet that morning or afternoon, actually, it was like at noon when the procedure was going down. I had this it's not like crazy that you touch the abdomen, but right at the left side under the rib, like at the rib cage edge. Mm-hmm. I had this discomfort, like a real discomfort, right? And it was like it's probably more related to the fact of emptying out, of the entire digestive tract, because I would gather that's what the purge did.
Yeah, again, I'm not sure exactly what they did to you, but again, my recommendation for sure would be, keep an eye on it. If you're not feeling right, go back to whoever your team is that's done that. This is definitely not my specialty. But again, can things hurt after a procedure? Yeah, absolutely.
Keep a diary
but I think to the extent that is expected, if it seems weird, then I think you need to obviously follow up and get that checked out.
We'll get to another one before we break. Raven, hello there.
Hi, how are you?
Good. What's going on with you?
Well, it's actually my husband. He's been having sciatica and nerve pain for the last 2 years consistently. The doctors and everybody said there's not much you can do with it, especially in regards to nerve pain. It's just something you have to tolerate until it gets better. He's been on oxycodone, gabapentin, and everything. It just seems to get worse. instead of getting better. I mean, what are options that he can possibly do? Because he's at the point where he's limping or dragging his leg.
So my question becomes, what's causing the nerve pain? So what's going on?
It just literally just starts up. Like last year, it was his left arm, and slowly over time, we've done chiro adjustments, massage, and everything like that. He's taken time off work months at a time, but there's not one.
Has he ever seen a neurologist?
He has. We've seen a surgeon back at Sunnybrook, and he said that it's not that bad for him to have surgery.
What is not that bad?
The nerve pain.
But who was the surgeon? What type of surgeon?
He was a specialist for nerves.
A nerve surgeon or like a spine surgeon?
Nerve surgeon.
Okay. I mean, for me, the thing where I would start is I would need to understand what is causing his widespread nerve pain, because that's how you can try to get to the bottom of, okay, how do you deal with this? So, whether that is peripheral impingements due to tight muscles or something more centrally like a disc bulge or some problem within the spinal cord, or is there something in the brain, which it doesn't sound like it based on the history and what you've seen. But again, that's what starts to pop into my head is I want to understand. You got to pinpoint the issue. Like, where is this all stemming from? If you don't find the initial point of where this is all starting, it becomes very, very hard to treat, because how you would treat a disc herniation that causes nerve pain is very, very different than how you would treat a peripheral impingement that causes nerve pain is different than how you would treat, diabetic neuropathy that causes nerve pain. So that's more of the issue where I would want to investigate is what exactly is creating this nerve pain in your husband. What is it? That becomes my question. Where nerve pain to me is just like someone telling me I've had a fever for 2 years. It's like my next question would be, well, what's creating that fever? Like, what causes that? Nerve pain or neuropathy is a sign. It's a clinical sign. It's not really a diagnosis to me. So, and I would say probably come and see me for an assessment and let's try to figure out, well, what is causing the nerve pain?
Exactly. I mean, we'd love to come and see
you
because
give me a call.
He's definitely been in this situation for the last 4 years.
Okay.
And there's absolutely no one that can. And we've gone to the various specialists and surgeons.
Mm-hmm. Well, let's.
No one that can help.
John knows the number.
Raven, thanks for the call. 1-855-55 Dr. Lou, DRLOU. Call that number and info at paincarecanada.com as well. More Dr. Pain shows on the way after a short break. Your phone calls too, right here, Global News Radio 640 Toronto. 11:43,
yes,
Dr. Pain
Jody.
Show. Look at that, just hitting the post.
Nice.
Settle down. Rockstar. 416-870-6400 star 640 on
he
cell.
Hit the post. Again.
He did, yeah.
He did it.
That's
time.
when,
okay.
we go
Radio
on
Basics.
Come
on,
man. We'll talk about that in the
radio
next show.
segment. Yeah.
Hi, Margaret. Good morning.
Good morning.
How are you?
I'm fine. Yourself?
Okay. What's going on with you?
Okay. On June 15th, while in Calgary, I cut my thumb quite deeply, so went to a walk-in clinic and received 3 stitches.
Okay.
About a week later, I'm now in BC, so the stitches were removed. So in that time, though, I am wearing a Band-Aid over the cut, right?
Mm-hmm.
So then about a week and a half ago, decided to remove the Band-Aid. And when I do, the surface skin separates. But if I put the Band-Aid on, because of the moisture, the skin goes back together. And this is what's going on, and I don't know why that's happening.
Have you gone back to see anybody about this?
I haven't because I've been on the go, but I
would make time for it.
Pardon?
I would make time to go find somebody and get it looked at properly. Like, I mean, it's an open wound that sounds like it's probably not healing the right way. And, that very much can increase the risk of some type of infection to develop. And, although the thumb, or finger seems like a small area, a bad infection, if not treated, can spread. So, I mean, I understand you're on the go, but I would say make the time, go somewhere like right now, today, and go get it looked at by, a walk-in doctor, an emergency room, whatever it is, and make sure that everything looks good. And if it needs stitches again, maybe that's the route you got to take.
Okay, thank you very much.
No problem.
Thank you. Appreciate that, Margaret. 416-870-6400 star 640 on cell to call. Talk to Dr. Lou, get some questions or some beginnings of. Anyway, David, welcome. How are you?
Pretty good, Dr. Lou. How are you?
Good.
Okay, Dr. Payne, I got a question. I work at the airport, and my job requires me to jump into a tug, hook up to an aircraft, and tow it from whichever it needs to go, right?
Okay. Yep.
Now, and I've noticed that ever since I've been working with this particular tug, it's the only type of tugs that we use, my left knee on the inner left side feels painful. So whenever I take a step forward, or whenever I have to jump into the tug or get off, there's some pain there. And I noticed that when I'm off for 4 days, it does go away, and then it gradually comes back when I get back to work.
Okay.
And so by the 4th day, it is painful.
Yeah.
So
So you know what the aggravating activity is.
Yes.
Okay.
How would you suggest I would turn around and try and mitigate that, or try to keep that pain from reoccurring? Would there be a method, or is there something?
So although you're explaining to me exactly what you're doing, I can't really visualize it. So I don't have any, background in that area. So I would say maybe come see me. We can go through kind of like, you can walk me through exactly what it is you're doing, and we could see if there's a way to modify it or change it so that it's not aggravating it. Or, you said something where you said there's a new tug versus, do you still have access to the old tugs at all?
They've been trashed.
They've been ago. So this is the new equipment. Yeah. So we'd have to try to modify your work. And we actually do this. We have a division of our team that does this for employers. Now, it has nothing to do with you because you don't own what you do, but where we look at what are the physical, like it's called the physical demands analysis, where we look at, what is the demand that you put on somebody, and then you do for the other side, the employee, the functional capacity evaluation. Can the person meet the demands of the job, and vice versa? Like, is there a pre-existing history, et cetera, et cetera? So we can do a mini version of that is essentially what I'm saying. We're not going to go to that extent, but you can walk me through exactly what it is you need to do, maybe take some pictures, bring it to me so that I can visualize it, and then maybe we can come up with a game plan on how you do something to modify it is the biggest thing. And hopefully that modification is enough to remove that repetitive nature that seems to be creating your problem.
All right, perfect.
Okay.
Thanks, Dave. Appreciate that. It's 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. Sandro, hello there.
Hi.
How are you?
I'm doing okay, I guess.
Okay. What's going on with you?
Well, okay, so for about a year now, I've been having this pain in my right leg. Radiates from my hip down to my knee. I have trouble crossing my leg. Went to the doctor. They took x-rays. They say you have mild to moderate arthritis in your hips and your knee. And I said, well, what do I do? And they said, just take painkillers.
Okay. So let me stop you there. Did the doctor move your hip around or move your knee, anything like that?
A little bit. I have been going to a physiotherapist.
Yep.
And he's been doing laser treatment, electroshock.
Yep.
So the biggest problem is the pain in the hip isn't as bad, but he says, like my thigh, like I can't cross my leg. All the pain's in my thigh, down in my inner, and he says that's all coming from the hip joints.
Okay.
And I can't seem to get this muscle to relax. He says you might have an issue with the IT band too. He's been trying to get the muscle to release. He puts a small little plunger on my thigh and he pulls on it to try to get the muscle to relax.
Okay.
But so I don't know. It just doesn't really seem to be getting better. The only thing I can do exercise-wise is ride a bike. Doesn't seem to bother me, but I can't even cross my leg to.
Does walking bother you?
Not too much.
Okay. All right.
I can walk.
So what's your question for me, Sandro?
How do I get this pain to go away? I guess.
Step one, you got to come see me. I have to see what's going on. Like, you could tell me that it's that, but my job is to not just take anyone else's, opinion until I see it and correlate it clinically, because, it could equally be from your back, right? Like, it might not be your hip. If you have mild to moderate, how old are you?
59.
Yeah, like mild to moderate osteoarthritis of the hip at 59 years old, to me, like, just talking to you sounds normal, right? Like, maybe I see the image and it's more than just mild to moderate, but not many people are going to get to 59 and not have mild to moderate. I'm interested in how does that hip move around through what's called a scour of the hip, like moving it around and seeing, does it have its full range of motion? That will tell me much more than just an image alone. And then, looking at the knee, looking at the functional capacity, maybe it has something to do with your gait. There's so many different things that are going through my head that, the only way for me to give you the proper advice is to assess it and see for myself.
Okay, I'm in the Falls. How do I get to see you then?
Yeah, give me a call. So my team is across Ontario, but you'll have to come see me in Etobicoke one time, 1-855-55 Lou, and then from there we'll book that assessment and we'll go from there.
More of your phone calls after a short break as we get into 12 o'clock and wrapping up this hour of the Dr. Payne Show. Global News Radio, 640 Toronto. 11:52, last few minutes of the Dr. Payne Show. Getting in your calls. Love to. Dennis, welcome. How are you?
I'm good.
What's going on?
I'm a type 2 diabetic. I'm currently on metformin, and I noticed over the last year I developed neuropathy, and my doctor prescribed vitamin B12 to address it, but I got numbness in both index fingers and my left leg to my midsection, and my sensitivity to heat and cold has been vastly diminished. And I was just curious as what the long-term prognosis is for neuropathy.
What's your blood sugar like?
My blood sugars are pretty good, anywhere between 5 and 8.
And that's your A1C, or just daily measurements?
Daily measurements.
Okay. Yeah, I mean, so this is the perfect example, where just for other people, when someone's calling, neuropathy is a clinical sign in this case, but we know what the root cause in Dennis is, being his type 2 diabetes. I guess it's very hard, obviously, for me to say a general prognosis, right? Because it very much depends on a lot of things individual to you. How quickly has it progressed recently?
It's progressing mildly week to week, so I can see it's increasing, but not significantly.
Okay, and do you still have sensation?
Oh, yes.
Yeah, you still have, but it's more the tingling sensations?
Tingling and sometimes pain in my midsection.
Okay.
When I'm showering, for example, I can really notice it.
Okay. Yeah, so I mean, it sounds like it's the start of it. The biggest concern with the neuropathies is, unfortunately, if you do a good job of controlling your blood sugar, then you should do a good job of controlling the unwanted side effects of type 2 diabetes, one of them being neuropathy. Obviously, if you don't do a good job on that, then it could progress quicker. So that's the biggest thing, is really try to manage your blood sugar as well as you can. The other thing to be concerned, just a couple things, is with the neuropathy, once people start to lose sensation, especially in the feet, diabetics tend to you might bang something and not notice because you've lost sensation. All of a sudden there's an open wound. That open wound may get infected. So it's good practice to just have, a loved one or someone whoever you might live with or someone around you, just periodically check, especially your feet, areas that would be more difficult for you. Just to make sure that there's no wounds, nothing that looks open, just because if there is, you obviously want to get that treated right away. But, it's very hard. The prognosis, it's a progressive disease, diabetes, so everything with it tends to progress. And that's the unfortunate reality. It just really comes down to doing your best to manage the blood sugar through, the use of your medication, your diet, exercise, and those types of things. So, it sounds like you're probably already doing those things. I would encourage you just to continue doing them and maybe talk to your endocrinologist as well about the neuropathy and maybe get them to send you to a neurologist or someone that specializes in that issue for diabetes.
Is there other medication besides vitamin B12 that could diminish the side effects of neuropathy?
Well, B vitamins are very good for the nerves. So your doctor's just giving you that to help the nerve function itself, because B12 and other B vitamins are part of nerve tissue. So that's not really a medication that you're taking. You're taking a supplement to help. The only other thing, once you get into nerve pain, is you start to get into, again, things like the narcotics, the opiates, and those types of things, the Lyricas, which are more psychoactive drugs. I don't think that that's necessarily the best step to go because of the other side effects around that, what it may do to your blood sugar, et cetera, et cetera. But, it's worth a conversation to be had with your doctor if you're concerned about it, if there is other medication that they might think might be a good idea for you.
Well, great. Thanks very much.
No problem.
Thank you, Dennis. You need Dr. Lou's number anytime, 1-855-55, Dr. Lou, DRLOU, info at paincarecanada.com. So there you go.
Simple.
A lot of stuff out there today.
Yeah, and again, when it comes to the free consultation over the phone, these shows are the best example of what they're like. Like with Dennis, I'm not saying, Dennis, come in and see me. I'm just merely pointing him in the right direction, and I'm happy to do that for people. And then other people, as you've heard me say, is come in for an assessment. I have to look at it. I had one person who called me and wanted all their answers this week over the phone and was like, I can't do that. Like, no. I need to assess you. I don't, why you would even want me to give you answers is beyond me, but whatever. But it's simple. It just starts with a phone call, an email. We're going to have a quick chat if it's something that I believe that I'm well equipped to assess, or someone in my team. There might be people in my team. I may not necessarily be able to assess it, but maybe someone in my team might be. It all starts that way. It's just a simple phone call with whatever your issue is. Again, we mainly tend to deal in the musculoskeletal issues, the muscles, nerves, joint pain, things like that. So, we had a call today about the colonoscopy. Not the right person for that. Right. But, if you're concerned and you just kind of want to ask a question, you've listened to the show, you want my opinion, I'm happy to give my opinion. Yeah, for sure.
So we'll take it from there. To get a hold of, if you haven't caught it several times throughout the show, it is simple, 1-855-55 Dr. Lou, DRLOU, email info at paincarecanada.com. Till next time, Dr. Payne Show, Global News Radio, 640 Toronto.